Good morning to every one of you. Now we are going to present another instruction course on the retropupillary iris lens for comprehensive ophthalmologist. As you know very well, there is sometimes there is certain situation and condition in which the posterior capsule is deficient, and in which is not possible to implant the IOL in the back, though it is very important. One of the it gives a good result, but in certain situation you have to opt for the different options. So we are going to highlight this particular this option, that is retropupillary iris lens, which is very much useful to everybody. And as you know, it is very safe, very easy, short learning curve, and everybody can implant the in very short time, and it also prevents the various complication as well. So without wasting much time, because time is very short, we have to start. And the first speaker is Dr. Aarti Singh. She is Associate Professor at RIO Prayagraj. He is going to present an approach to a patient of deficient posterior capsule and various surgical options.
So good morning everyone. My topic for my discussion is approach to a patient of deficient posterior capsule and surgical options. As we know, in the back posterior chamber intraocular lens implantation remains the best anatomic location for an intraocular lens. But there are causes where there is absence of capsular journal support, like complicated cataract surgery, trauma, and cases with big zonules. So how to proceed in these cases? We have to do the preoperative evaluation. So we have to review the prior medical records, examination of anterior and posterior segments. We have to look for vitreous prolapse in anterior chamber and examine the residual capsular journal support. So what are the surgical options? If the posterior capsular rent is small, in the bag intraocular lens is the good option. If there is significant loss of posterior capsule with intact capsulorhexis, sulcus fixated intraocular lens can be considered. And if there is no capsular journal support, anterior chamber intraocular lens, scleral fixated lens, and iris fixated lens are the other options. So if the posterior capsular rent is small, in the bag implantation is always a preferred option. If it is central with a well-defined border, try to convert into the posterior capsulorhexis. That will make the tear strong and resistant to peripheral extension. Then the next is the leading haptic is first placed between the remnant of anterior and posterior capsule, and the trailing haptic then placed with the help of compression maneuver. One thing should be kept in mind that in the bag implantation should be performed in early postoperative period before the formation of anterior and posterior capsular adhesions. So if there is significant loss of posterior capsule with intact capsulorhexis, in this sulcus placement with or without capture is the best option. Here the 3-piece hydrophobic intraocular lens is always preferred, as it fit better in the sulcus. While the single piece lens, which is smaller in size, usually got decentered, and its thicker haptic may cause iris chapping. And it is also better if we can do the optic capture, as it provides more stability and more centration to the sulcus fixated intraocular lens. And as we already know that these lenses are slightly anterior, so the power should be adjusted, and it nearly corresponds to 5% reduction from the predicted capsular bag IOL power. So what are the options where there is absence of capsulojonular support? The first is scleral fixated lenses. Their advantage are it can be placed if there is no capsular support, if there is no iris support. The other thing that it is away from the cornea, so the chances of corneal decompensation is less, and so this surgery can be performed in the patient of corneal endothelial diseases and also in cases of shallower anterior chamber. There are two techniques of doing scleral fixated lenses: sutured scleral fixation and sutureless scleral fixation with fibrin Yamane technique, but there is no study to prove superiority of one over the other. Drawbacks with these lenses are that these lenses are usually needs more surgical expertise, and the chances of IOL decentration and tilt is also higher in these cases. Other than that, these sutured lenses usually got through the knot erosions and late suture breakage. While the cases with the sutureless scleral fixation technique, there are chances of intraocular lens dislocation is also high. The other technique in these cases are anterior chamber intraocular lenses. The previous older design, closed loop designs, there were more chances of UGS syndromes, but with the modern open loop designs, there are less associated complications. In these lenses, risk of pupillary block is usually high, so a peripheral iodectomy is always performed, and most of the complications of ACIOL can be prevented with appropriately sized lens, but the problem is that the only limited sizes of ACIOLs are available. An overly sized lens can cause damage to angle, may form peripheral anterior synechia, and can cause more inflammation, while a small lens, which is more mobile, can cause damage to corneal endothelium. And these lenses are slightly closer to the cornea, so the risk of corneal decomposition is also very high. So these cases, in cases of corneal endothelial diseases, in cases of where there is no iris support or where there is angle abnormalities, these lenses are usually contraindicated. The next is iris fixated intraocular lens. These lenses are usually enclaved at the mid-peripheral iris, so the pupillary dilatation is usually not hampered. It can be fixed to the anterior to the iris or to the posterior to the iris. But we usually prefer the retropupillary approach because its position is more physiological. There is no need of doing peripheral iodectomy, and the lens is usually away from the cornea, so the chances of corneal decompensation is also very less. The other advantages with these lenses are there is quicker visual recovery, lower invasiveness, shorter surgical time, and shorter learning curve. The only requirement with these iris fixated lenses are that it need only 270 degree of iris tissue, and the pupil size should be smaller than 6 mm. The drawback mentioned in the literature are oval pupil, iris chafing, pigment dispersion, but in our patient we have faced very fewer of these complications. So, if there is lack of posterior capsular support, or if there is fibrosed anterior and posterior capsule, so in the back placement is difficult to do. If there is inadequate capsulojonular support, sulcus intraocular lens implantation should not be considered. If there is poor corneal endothelial health, shallower anterior chamber depth, abnormal angle, anterior chamber intraocular lens is not a good option. If there is scleral abnormalities with scleral thinning or scleritis, scleral fixation technique is not a good option. If there is inadequate iris support, if pupil is large in size, if there is uveal inflammatory disease, iris claw lenses should be done judiciously. In conclusion, careful patient selection is critical in these patients. When possible, capsular bag is always preferred, followed by sulcus implantation. But when there is no capsular support, iris fixation, ACIOL implantation, and scleral fixation are the other approach. Anatomic consideration and surgeon familiarity with the IOL technique determine the type of surgery. With lesser invasiveness, shorter surgical time, and learning curve, we found retropupillary intraocular lens a suitable option. Thank you.
Thank you, Dr. Arthi Singh, for a nice presentation, excellent presentation. You have already opened the options through the hall, to the audience. Now this is up to you to choose which option is better, but definitely I can say this retropupillary RE class lenses is better because these different the procedure have the advantage and merit and demerits. So we will conclude the last which is better. So I invite to the next speaker, Dr. Shivangi Singh. She is assistant professor at MGM Medical College, Mumbai. Is going to present the various the technique, real technique of the retropupillary college. Welcome.
A very good morning to everyone. I am Dr. Shivangi Singh, and I'll be talking about the retropupillary iris claw lenses. So, once. Not working. Yeah. So sorry. So starting with the introduction, these iris claw lenses has been increasingly chosen by the surgeon because of its simple technique. It has a lesser learning curve and it is easier to perform. Also, it is as efficient as the scleral fixation IOL. So the various options available as secondary IOL include the anterior chamber IOLs, the posteriorly enclavated iris claw lenses, and then the posterior chamber SF IOLs. So iris claw, as already discussed by ma'am, it can be placed anteriorly or it can be placed posteriorly, but posteriorly it has more advantages. So I'll be directly coming to my video and I'll be emphasizing mainly on the surgical steps of iris claw lens implantation. So starting with the first step, it's not necessary for everyone, but it's useful for beginners. So we can use this toric marker to mark 0 and 180 degree, which are the two opposite sides of the side port that we need to enclavate the iris claw lens. So after we do the marking, we can now make the side port. Just see that the side port that we make, it is limbal, it's a single stab wound and it's a short tunnel. So this short tunnel is really helpful us to reach the mid periphery, which is the exact point on the iris tissue where we have to enclavate the iris claw lenses. Otherwise, if we enclavate it at far periphery, it will cause ovalization of the pupil. So that we don't want. Then after that, the anterior chamber can be stained with the triamcinolone. So this triamcinolone helps us to visualize the prolapsed vitreous better, and then we can perform the anterior vitrectomy. It is important to perform the anterior vitrectomy properly and remove the anterior chamber of all the vitreous strands that are there. Once the anterior chamber is clear of all the vitreous, we can now place the iris claw lens under the air bubble over the iris tissue. It is then dialed horizontally so that the two notch of the haptics are at the vicinity of the side port. The air bubble is then replaced by the viscoelastic tissue, and then we can now enclavate the iris claw lens by holding it with the iris claw forceps and then enclavating it with a blunt instrument. So once it has been enclavated, we can see a nice tuck. I'll just zoom it and show the nice tuck that we see, a dimple that ensures that the iris claw lens has been enclavated properly at its place. Similarly, on the other side as well, we can slide the iris claw beneath the iris tissue gently without damaging the tissue, and then we can lift it a bit so that we get the impression of the iris claw over the iris tissue. This also helps us to know as to where we have to enclavate exactly. So we get a nice round pupil at the end of the case. This was another case of aphakia which was planned for secondary IOL. So we went ahead, did the marking of the side port, but do note that the marking need not be as prominent as we have done in this case, because then this will cause hindrance in visualization while we are enclavating the iris claw lens from the side port. Rest steps are the same. We do the anterior vitrectomy, and then we implant the iris claw lens. So the reason why we place it under the air bubble is that now the iris claw will cover the pupillary margin, and when we replace this air bubble with viscoelastic, there are lesser or no chance of viscoelastic to trickle down into the posterior chamber. So yeah. So one more trick I would like to show how we hold the iris claw lens. So with the help of this iris claw holding forceps, we hold it in such a manner from the center of the optic such that the flange of the forceps coincides with that of the notch. So this gives us an indirect clue when we are beneath the iris tissue as to where exactly we have to enclavate. These small points are important to get that enclavation in just a single tuck, because if we do multiple tucks, multiple attempts to enclavate, we can damage the iris tissue over that area, and this is reason for iris atrophy later stage, and one of the reason for late disenclavation of the iris claw lenses. So now I would like to show few cases. This first case was a case of traumatic anteriorly dislocated nucleus. And while I was dialing it out, I observed that there was no capsular support beneath it. So I gently just dialed it out of the bag, prolapsed it into the anterior chamber, and then I delivered it out through the sclerocorneal tunnel. And after that, anterior vitrectomy was performed in a routine fashion. So here I would like to emphasize that while we are implanting the iris claw, we can also use pilocarpine to constrict the pupil. So the concavity you see, it's anteriorly, so it is placed upside down. This concavity helps us to maintain a safe distance between the iris tissue and the lens. So there are very less chances for glaucoma because of this concavity modification of the iris claw lenses, which was not there previously. And so there is no need to perform peripheral iridectomy in iris claw lenses now. We can also use this iris repositor instead of Sinskey hook because it's also a blunt instrument, so it is less traumatic to the iris tissue. This was another case of inferiorly dislocated IOL. So luckily it was in the anterior vitreous only, so I gently dragged it out through the anterior route through the sclerocorneal tunnel, and after that I stained the prolapsed vitreous with triamcinolone. While performing the vitrectomy, make sure that the mouth of the cutter is always facing upwards and away from the iris tissue, so as to prevent any iatrogenic damage to the iris tissue by the vitrectomy cutter. And it is important to release all the tractions that are there, because if we do not, if the traction is not released, it will cause chronic inflammation, and there are chances of CME and retinal detachment. So our aim is to get a good round pupil before we implant the iris claw lens. Then rest of the steps are same, implanting the iris claw in a routine fashion. And the tuck we see, that's at the mid periphery. So that is very important that we tuck at the mid periphery. This last case is a case of aphakia with a deficit posterior capsular support. So initially I had planned a 3-piece IOL for this case, but I could not get a sufficient good support for this eye. So I went ahead, did the anterior vitrectomy, and then I implanted the iris claw lens. I had iris claw lens at my rescue. So the tunnel that you see, it's the tunnel should not be more than 5.4 to 5.5, which is the maximum vertical diameter of the iris claw lens. So a small tunnel will do, need not be as large as we make for SISIS or PMMA lenses. Then rest of the steps are same, and we tuck the one end followed by the other end. So these are small tips that we can use, although it's a easier technique, but these techniques helps us to place the iris claw at the center of the pupil so that there are very less chance of decentration, ovalization of the pupil, or late disenclavation of the iris claw lenses. So thank you. I'll just end my talk over here, and I'll hand over the mic to my next speaker for the next topic. Thank you.
Thank you. Excellent presentation. Just I would like to highlight the certain things in this. As you know, have you seen how much this very easy procedure? The learning can be very short, and you can complete the inclination of that is within a minute. It takes hardly 1 minute. So you can cut down the surgical time. Once you cut down the surgical time, various complications can be prevented itself. One, I would like to highlight one important point, that insert the IOL. After doing the anterior bacterium, inject the air, and then implant this, insert the IOL inside the anterior chamber under the air. So what will happen? It will and then replace it, and then block the pupillary area with the lens, and then replace the air with the visualize. So it prevents going the this visualize behind in the vitreous. So it prevents the various complications. So this is one important thing, and you know, only few complications is reported in the literature. Only sometime that is ovalization or decentration. So once you know the real technique, it can, there's no any hardly, you have seen so many cases shown by the Dr. Shivangi Singh. There's people so round, no ovalization, and centration as well. For initially, centration has very nicely demonstrated how to enclavate in the centrally, how in the pupillary area. Thank you very much. Now next speaker, Kamal is not available, so not present at present. So I would like to just call upon the Dr. Vinod Singh, the vitreoretinal surgeon, excellent vitreoretinal surgeon, RIO Prayagraj. So certain situation, if the nucleus arrival drops, then how to remove it, and then how to this implant the retropupillary iris. Dr. Vinod.
So there are the few contemporary the incidence is around 0.3 to 0.1% of the cases the PCR occurs. These are the few risk factors in which you have to be careful before starting your surgery, so that you are prepared for the next step. You have all your armaments in the tray, so that you can manage the PCR immediately and not panic when it happens. Like though patient we are head vitrectomy has been done prior, and there is no compromise, pseudo exfoliation, floppy iris, myotic pupil, hypermature cataract, posterior polar cataract. These are the cases where there is a chances of always there is a PCR is there. So you will know your case before starting your surgery. You are prepared for the next step, and you will do nicely the iris claw lenses and manage properly the PCR and give a good outcome. The nucleus drop complications are like corneal edema, high IOP, vitreous hemorrhage, cystoid edema. So we are always prepared that it does not happen, but few cases you cannot avoid it. So first is how to recognize the PCR. There are the few points. When PCR occurs, there is a sudden pupillary constriction during the hydro dissection. You can notice very nicely. There is a sudden deepening of a anterior chamber. We can see sometimes striae of the posterior capsules, and there is also tremulousness of the nucleus, and you may feel difficulty in rotating your nucleus. Then you should be careful that there is something wrong behind the nucleus. And you may also see there is a excessive sideways tilting of the lens when you implant the lens. So there is a chances there may have PCR has occurred, but you have not noticed. So these few points you can see, and then you should stop and think of the ahead how to manage this. So firstly, how you can prevent the drop if it happens. Then tip of the phacoemulsification can be kept away from the capsule by the instrument positioned behind the nucleus. After being extracted from the posterior chamber, the nucleus should be emulsified at the iris plane, so it may not go behind in the vitreous. And your aspiration mode, the posterior capsule can be uncovered by using the phaco probe tip to scoop off the soft lens material out of the narrow spaces. It could be necessary to lift the larger particle into the anterior chamber by using viscoelastic and eliminated by the hand rather than using the phaco probe. There are the few techniques how to perform the anterior vitrectomy. You should have a closed anterior chamber. Suppose your wound is leaking with the main port or the side port, you should have a closed chamber. Reduce the bottle height. Your vitrectomy cutter should be, the cut rate should be the highest what you have in your machine, around 8 to 10 thousandths, and your vacuum should be the lesser side, around 250 millimeter of the mercury. When your cut rate is high and the pulling of the vitreous is not there, so you prevent the further complication, so you always have the high cut rate. This all already has been told. We'll see some video. There is a cortical matter. You can see the IOL is already there in the sulcus. So I try to first bring the IOL in the anterior chamber so that you cannot you avoid damaging the remaining peripheral support, and you can nicely clean the remaining cortical. If IOL is there, sometime you can cut the remaining iris in the posterior capsule while removing the cortical matter. So better to remove the IOL anteriorly, and also go inside and just see any some fragments are lying in the vitreous cavity. You just pull it or suck it with your vacuum, and then you cut it. You do not cut or use the cutter near to the iris or behind the iris. Always avoid. Just you can pull and keep it in your view so that you can avoid damaging the iris. And after doing a good vitrectomy, you see that there is no iris vitreous tag. If you are sure, then you can just see once again the support is proper support is there, but just pulling the iris. And also you will inspect for any cortical matter lying there. And then you can implant your lens in the sulcus. The second case, there is a nucleus drop is lying in the vitreous on the retina. Just go first do the anterior vitrectomy, clear the iris plane, pupillary plane, then you perform the cortical vitreous vitrectomy. You have to nicely do vitrectomy that your nucleus is free. While manipulating or removing the nucleus, there should be no touch of the vitreous with the nucleus, so it should be free floating. And I use here the lens, this probe, light probe, and the cutter. Just pierced it and took it out in the anterior chamber. Mostly I prefer this technique instead of using a phagophragmatome. For phagophragmatome, you have to increase your the side port, then you have to use the sutures, so it also takes less time to remove these pieces instead of clearing with the phagophragmatome. In this way, you also avoid if you are not done some peripheral vitreous is there, you can avoid the complication, because if you are using phagophragmatome, the opening of the phragmatome is so big, sometime you may catch up the vitreous and the complication may happen like tear, detachment. Sometime if your chamber is not maintained, your eye may collapse while using a phagophragmatome. This is another case of aphakia with the cortical matter in the periphery and anterior chamber. Use your irrigation. Your irrigation port should be pointing parallel to the iris. It should not be towards the vitreous and not towards the cornea. If it's towards the vitreous, more vitreous will come out and you will not able to do a good vitrectomy. So it should be parallel to the iris. I already pointed that your tunnel, side port tunnel should be small. You should not be big. Otherwise, you will not be able to incavate it properly, and there will be ovalization of the pupil. So it should be small, not like you are making the side port usually in your phaco and other procedures. Thank you.
Thank you, Dr. Punat, for a nice presentation. You know, certain situation, the lot of the complication happens with anybody with any expert hands. So management is very important. They have shown very nicely how to manage it and how to implant in a very quick time, the short time, the posterior iris lens. Thank you.
Next, I would like to invite our next speaker, our Chief Instructor, Professor S.P. Singh. He is very eminent surgeon, ex-principal, ex-director of RIO Motilal Nehru Medical College. He is going to talk on combined iris reconstruction and retropupillary iris claw implantation. Sir.
So again, very good morning to every one of you. Just a little bit back. Just start again. Yeah. So, as you know, this nowadays this retropupillary iris lenses has increasing popularity among the this general ophthalmologist as being a very simple procedure, very short dynamical that can be implanted in any situations. But the posterior iris classes needs sufficient iris support as well as ideally normal the pupil, normal shape and size. But however, the iris can be implanted in the iris injury, minor iris injury, as well dilated pupil as well. So that I am going to present different cases, different difficult cases. Even these situations, the iris damage is there, or the pupil dilated, atonic pupil. In these situations also, the posterior iris can be implanted very well. So once you know these complicated situations, then you can see and watch and observe, and you can decide even any condition the iris can be implanted very well, very safely, very effectively. So I'm just present some of the just play this video. Yeah, okay. So different cases. You know, this is the capsule, this corneal opacity with dilated pupil, dilated atonic pupil. You can see after removing this scarred cornea, you can see how much atonic pupil are scarred, adhered, this pupil is there. So mechanically, first you have pull all around the iris, and then in this case I decided to the pupilloplasty by circlage technique, in which by persisting technique, in which take the 10-0 monofilament this suture, nylon suture, and then all around the pupil it is passed the sutures 0.5 mm away from the margins all around, and takes the bite at different site 1 to 2 mm away. So in the various multiple the places you have to place the sutures all around the pupillary margin by just that is this technique is the circlage technique, in which that is persisting suturing technique. And you can just after passing this 10-0 sutures, you can just tight it, and then you can see that how you can bring back the new this pupil can be made the appropriate size 4 to 5 mm. And then before tight it, you insert the retropupillary iris lenses and then incavate and the periphery, as is demonstrated by Dr. Shiva very nicely. And you know, this is in these cases, this is the only better option, because you know, in the open sky you have to shorten the time. Otherwise, in hypertonic cases, various complications may take place, like the hypertonic myelopathy, the choroidal hemorrhage. So many complications may happen, and you can see in this case, by seeing this case, you can decide yourself how this procedure is very simple, and there is no other option except the retropupillary iris is better. So you can just after then implanting the iris lenses, you can tighten the sutures, and you can do even this condition. This is another case of the this opaque cornea, in which the iris deficient is there. In some of the cases, only few places that this iris tissue is there. Earlier speakers told that it requires at least the 270-degree iris, but you can see how much capsule is deficient in this case. So just mechanically pull it. Where any additions are there, just remove it, mechanically pull it, and you can see in this how in this small, this how much large defect the iris got. This ask the assistant to hold the margin of the iris, because your two hands are already engaged. To help assistant, just hold with the help of forceps at the margin, and taut it so that it can be enclavated even this small, even this large iris defect, and then this hold it again with the help of assistant. Hold it and tighten this so that it can facilitate the enclavation of the iris lens in the such a remaining tissue, and this you can very short time you can implant the IOL. You can see it is how much is stable. There is nothing, no movement, not at all, and even this conditions also. So in there is hardly any contraindication of iris, this posterior iris lenses, and then you can implant in such condition. These are some difficult cases. So this is the case of the partial anterior osteophylloma. Partial anterior osteophylloma, in which you can see the this evil tissue is adhered, this incarcerated, and then refine it slightly towards inferiorly, and you can watch this what to do and what options you have to choose. And then after this cornea, I am just planning to remove the this nucleus, but you know it happens. Certain it may happen. These such type of situations, bitters may come, but hardly takes any. You can see after doing the vitrectomy, and the defect is bound to occur, because this is a case of osteophylloma, partial osteophylloma. So you can do what to do, how to repair in such a gone case, but hope for the best. Even in the osteophylloma cases, how you can provide the best vision to the patient. You can see the repair. Every individual case you get different technique of the this pupilloplasty or the iris repair, and you can see in such a defect how you can repair the pupil and make the appropriate size of the pupil. And the individual, you know, if once you see the different cases, different complicated cases, so you can also think, you can also decide what to do, and anybody can do and do the complete the surgery and repair in such case. Then from the remnant part of from the periphery, you can repair in this direction. Only you should observe, then you can learn a lot. Only observing you can learn a lot. And how, you know, this was the case of the osteophylloma, in which the you know, the osteoma, this incarcerated tissue is there. So iris defect is bound to be there. So you can see how to repair it and make the pupil almost circular. And in this sky, in this case, there is no any option except this is the only option. You can't do such open sky, the scleral fixation or angle supported. So another case, you know, and this traumatic posterior dislocated this lens along with the atonic pupil. So I decided first to remove it. Then once the irrigation is on, the nucleus automatically comes interiorly, and lens comes interiorly. So you can, my job becomes easy. You can see again how much atonic pupil is there. So mechanically pull all around. So and then assess whether it can be bring back or not in the center. Now even this such a dilated pupil, thus I am going to the implant again. You can see, because it inclination takes mid periphery. So even you can implant is such a this is such a dilated pupil very well, and then After that, there are different techniques. This educated by this popularized by the Dr. Amargwar, single pass four through pupilloplasty, in which make this paracentesis at different places and pass the sutures, polypropylene suture 10-0, and then how you can see how you can repair this dilated pupil. So once you know. Once you observe the different cases, anybody can do. Again, I told you that how you can this make the pupil this is small. As you know, the size of the lens is 5.5 mm. So at least the pupil should be less than the 5.5. That is 4 to 4.5 mm. And with different techniques, the pupilloplasty and the nuclear you can this dilated pupil, how you can make it circular. Small pupil. You can see again, this is the case of a phakia with dilated this atonic pupil, and again this the synechiae is there in the periphery. So with the help of spatula, break the synechiae, do the anterior all around, especially in the anterior chamber, and again just pull it slightly, release the anywhere if the synechiae is there. So in this case, again I am good different techniques. There are various techniques. I am again in the closed chamber how to do the this circular techniques. Make the side port different places and take this straight needle, this long straight needle, 10-0 polypropylene suture, and throw this all around. Take again in the margin this 0.5 mm away from the margin, and different places you have to different bites, multiple bites you have to take, and then externalize this needle at another end of the side port. Throw a 27 cannula, just feed it, and then you can see even this closed chamber how to do the circular technique. So circular technique, because the pupil much dilated, so very difficult to bring make the pupil circular. So this is the circular technique is very much helpful. There are various the other mechanical techniques also. So there, then again from the another side, take the double or another this needle from the different sides, and then pass in the multiple places, and then you can retrieve it. Is one port, both this ends, and then see how you can implant this retropupillary. Class 10 is such a dilated, difficult cases, and then after this inclavating the iris claw lens, and then you can tie the suture, and you can see this is the picture, the post-operative, and now another one or two cases there, difficult cases. You can see in this case this is a case of phakia. Only a remnant of the iris is there, one particular portion. So I decided to do in this case the aniridia fixation lens, but you can watch what to do in this situation. So after making an incision, it's going to turn it and injecting the valence solution. I observed lastly that this is not only remnant, but this is the severe ardoderisis. Case of severe ardoderisis happens during extraction of the nucleus by some of the trainees. Is referred case from some other center, and you can see how much the attachment is only one few very small area, and in this situation you can see how how difficult cases. It's a gun case. I decided earlier to do the this aniridia lens implant, the aniridia lens, but you can see how you can repair the iris. So it's very important to learn the this iris repair. This is case of large ardodialysis, how to repair it. You can see, and then again earlier it was only remnant of iris was visible, and then from different places make a scleral group. So where you can bury this knot, you can see in the how can repair such a large ardodialysis case. And in this situation, this again how to implant the iris claw lens in this situation. And so this so you can see after you can observe different cases. So definitely I can say now in this stage the posterior iris claw lens is a better option, because as this inclination it takes very short time, short learning curve, and any situation, any conditions it can be implanted with very stable lens without much without any tilting or disorientation. You can see I'm going to implant again this posterior auricular lens in such a situation. You can see this picture. So last case, this is a very rare case. This is the case of very rare case of this iridocysis and with the posterior dislocation in the subluxation of the lens, another dislocated lens, though it is present in the anterior vitreous. So even this situation, this is a condition of this iridocysis, rare condition, in which the stents, the iris stents are this moving in the vitreous just like a shredded wheat, and then first remove this whole lens. Though it's broken, but anyway, you can do the vitrectomy. You can see this is the case of iridocysis. All the stents of the iris stoma is moving. This iridocysis, there is separation of anterior and posterior stoma. Even this condition, let's inject the air, and then even in this situation, you can see the stability of the iris claw. Even in this condition, in which the retinocysis there, when this hardly this stoma is separated in 2 layers. And even this case, so I can just demonstrate that this posture are very safe, very predictable, and very effective method in any condition, any situation, and rather than the other technique you can't do in this case the anterior iris claw lens. So you can see again how to implant even in this situation where this iris hole is moving. And you can implant, you can see this is rare case, but even this situation, how this is the pupil well centered, how you can implant the lenses is appreciated. Thank you very much from Holy Kum City, Pyasdar.
Thank you, sir. You have shown us so nice cases and we do different scenarios. Even in the cases of iris tissue defect, you can do a good pupilloplasty and implant the lens. Even you can implant the iris lens and then do pupilloplasty, in which way you are comfortable. Both way you can go. It's up to you. One thing is important here. You have to see the inclination side, that the good iris tissue is there. Healthy iris tissue or amount of iris tissue is good. There is no atrophy or hole. And it is not always important that you are implanting your iris lenses 180 degree. You are not having a good tissue at the 180 degree, you make rotate your lens. You can do a little bit sideways where you have a good support of the tissue. Thank you, sir. Now Jiten is representing another case.
Good morning, everyone. I would like to thank Dr. S.P. Singh, sir, to give me an opportunity to include in his instruction course. I'll be discussing complication associated with the iris claw lens implantation, a beginner's perspective. Like for deficient posterior capsule, we have to choose a better option. We have to choose a better option in respect of safety profile with minimal complication. So it is important to assess complication associated with various options available for secondary oil implantation in deficient capsule. So what thing we can expect in retropupillary iris claw lenses? First of all, we started with surgically induced astigmatism. SIA always related to the size of incision. In retropupillary iris claw lens, SIA is less as compared to scleral fixated PMMA lenses because of the less optic size, which is 5.5 mm. So lesser SIA in case of retropupillary iris claw if we compare from SFIL. Pupil ovalization. Although the round pupils are desired at the end of the surgery, but the pupils sometimes develop horizontal ovalization. So in order to prevent this, this is a small video with this depicting that our stab incision should be a post-limbal incision with a short intracorneal length, and it should be diagonally opposite 0 and 180 degree with enclavation at the mid-peripheral iris. And gradually enclavation at the mid-peripheral iris. This is how we should do. Now another complication we can expect is the transient IOP elevation, which can be as a consequences of the iritis, pigment dispersion, and can be because of retained viscoelastic. This is another short video like implanting IOL in presence of hair so that we can prevent posterior migration of viscoelastic into the vitreous. So post-operative inflammation will be less. gradually removing the air with viscoelastic. So it prevent posterior migration of the viscoelastic into the vitreous. So post-operative inflammation will be less. Another complication we can expect is corneal endothelial cell loss. When an iris claw lens is fixated posterior to the iris, eyelid is in similar position as the crystalline lens away from the corneal endothelium, and the risk of corneal endothelial loss is also lower than in the ACOL. So retropupillary have lesser endothelial cell loss compared to sclera fixated, because in sclera fixated implantation we have a longer surgery time, and obviously we know ACL are expected with loss of more corneal endothelial cell losses. Another complication, a rare complication we can expect is cystoid macular edema. It can be caused due to chronic low-grade irritation of the iris, and due to persistent vitreous traction due to incomplete vitrectomy may cause. So removal of vitreous from the anterior chamber is must before putting an retropupillary iris claw lens. A disc inclination of the lens can be there. A disc inclination can be derived from insufficient primary inclination, which is often occur with the inexperienced surgeons. Iris atrophy can be reported up to, though rare, is very reported in around 24% of retropupillary iris claw lens implantation. Another complication we can avoid is like decentration of the lens. To avoid this, we have to put the tips of the forceps aligning with the notches in the haptic. So there should be a line. There should be a line. The tips of these forceps should be along with the notches, so that we can enclave at 180 degree apart. This is to prevent the decentration of the lens. Again, this is a video like with the help of a toric marker, we can mark 0 and 180 degree. Everyone is using this toric marker, that 0 and 180 degree we can mark, and gradually we can enclavate and prevent the decentration of retropupillary lenses. Like to conclude, that implantation of retropupillaries are associated with minimal complication compared to SFIL and ACL. These complications can only be avoided and managed effectively, and it should be the procedure of choice for secondary implantation. Thank you.
Though I have told about some of the complications, but I have seen hardly any complication or any problem. Ovalization also can be prevented if human technique, as Dr. Simangi Singh very nicely demonstrated how we can prevent the ovalization. So this option is definitely far better. Having hardly any complication. Now, very quick, I request the next speaker, Dr. Prasta, who is Director RIO Prayagraj. She is going to present on the demerits of the iris claw lenses. Have you seen, after observing so many talks and the cases, you can already assess what is the merit demerit. But anyway, she will tell about what are the merits and the demerits of the approach iris glasses.
Thank you, sir. Very good morning. First of all, I want to give the thanks to Office Scientific Committee of All India Ophthalmic Society for giving me this opportunity, and the SP Singh sir for giving me this opportunity. There's a conflict of interest as none, and there's a no financial disclosure. According to the NPCB VI, during the cataract surgery, the prevalence of complication rate is 1.2%, and out of which the prevalence of posterior capsular rent varies from 0.5 to 5%. That is, depends upon the surgical techniques, depends upon the experience of the surgeon, and depends upon the cases. As you saw, there were so many of the complicated cases, and patient factor too. The prevalence of large capsular rent varies from 0.5 to 2%. These are the cases where it is not possible to put the lens either in the bag or in the sulcus. So these are the patient we are generally leave the patient aphakic. So if the patient is aphakic, the visual disturbances can lead to the blurred vision, glare, sensitivity, difficulty in depth perception, and all these visual incapabilities lead to frustration, anxiety, and dissatisfaction. There's a very limited corrective measures are available in the form of glasses, contact lenses, and intraocular lenses. Where sight meet innovation, the aphakic lenses redefine the vision. These are the different options are available in the cases of aphakia. These are the like the angle supported lenses, iris claw lenses, and different type of the scleral fixated lenses. This is the algorithmic approaches for the selection of IOL in the presence of, in the absence of posterior capsule and absence of intact anterior capsule with a sufficient amount of iris tissue. The ICL is a choice. This is a comparative table between the ACIL, ICL, and SFIL. They showed the potential complications are more with the ACIL and the SFIL, and the risk of glaucoma is also more with the ACIL and SFIL, while there is a very less risk with the iris claw lenses. And it is also, as you saw the so many complicated cases shown by the sir, these lenses are very much suitable for the complicated cases, complex cases. The grip the future of vision with the iris claw lenses. These are the aphakic intraocular lenses designed for implantation on the eye without capsular support. Then the claw-shaped haptic system is a unique of this iris claw lenses, which is enclavated onto the mid-peripheral of iris and providing the stable fixation. First iris claw lenses was described by the Epstein in 1954, and first iris fixated lens was implanted by Kohler in 1960. And presently what the lenses we are using, it is a modification of the iris claw lenses, which is implanted by the Wurst in 1971, and these are known as the Artinson's lenses. Generally, these iris claw lenses are fixated in the mid-peripheral part of the iris stroma, which is less vascularized and less reactive. So the iris physiology and shape of the pupil is not altered. The size, it is a small in size as compared to the normal size of the lenses. The length is 8.5 millimeter and the breadth is a 5.4 millimeter, and it is generally not dependent upon the cornea white to white measurement or the eyeball size. So it can be implanted in a nano-ophthalmic eye. It is, but the only drawback is it is a rigid Palma lenses. So the size of incision is about the at least more than 5.4 millimeter. We can reduce the surgically induced astigmatism by this for this iris claw lenses. We can make the scleral pocket incision which induce less astigmatism. Now we come to the position of the lenses. We are gradually shifting the position of ICL from the antipupillary to the retropupillary, results in improved function because now it is more towards the physiological position. The optimization of the design is a second part that is called the concavo-convex, result in reduced complication like iris chafing, inflammation, and pupillary block. The lack of proximity with the corneal endothelium and iris fixated lenses, especially the RP-ICL, have less corneal involvement, but the large size of the ACIL could damage the cornea and corneal endothelium, causes a corneal edema, endothelial decompensation, and pseudophakic bullous keratopathy. It can be used as a primary procedure because of the short learning curve. ICL implantation is easy to place and require iris enclavation in a very less time. So it can be done as a primary procedure, especially in the patient of this PK. The scleral fixated lenses is a choice because it reduce this scleral fixated lenses are implanted in more physiological location, but suturing technique is difficult and require longer surgical time. Now we come to this ICL with the penetrating keratoplasty. It can be used as a combined procedure with the penetrating keratoplasty, as the hypotonic open sky phase is limited by implanting the ICL, so it reduces the chances of hypotonic maculopathy, macular edema, or choroidal detachment. Now we come to this complication associated with ICL. One is intraocular pressure. As we comparing the ACIOL, SFIL, and ICL, this raise in IOP is more seen in a ACIOL because this ACIOL is a large in size and this haptics settle in a root of the iris, leading to the damage of the anterior chamber angle and formation of pus that will further increase the intraocular pressure. In the case of SFIL, the higher risk of glaucoma is due to chronic irritation of the ciliary body, and incorrect suturing placement can lead to further increase of the intraocular pressure. But in the case of ICL, especially retropupillary implantation of the ICL, that will lower the incidence of the IOP rise with RP-ICL, because the temporary rise of the IOP can be there because of this post-operative inflammation and retained viscoelastic inflammation, but it responded very well with the anti-glaucoma medication for the few days. Now we are comparing the AP-ICL, the antipupillary ICL versus retropupillary ICL. The peripheral iridectomy is needed in the patient of this AP-ICL to prevent the pupillary block and rise in IOP. but a pupillary block does not happen with the convex concave vault design of this retropupillary ICL, and the peripheral iridectomy generally not needed with this RP-ICL. When we are comparing the ACIL versus SFIL, the study suggests the incidence of IOP rise and glaucoma escalation was slightly higher with the ACIL than with the scleral fixated PCIL. The iris inclination done in the mid-peripheral part of the iris, which has got a lower blood perfusion and less reactive. So iris atrophy is reported in a 24% of the retropupillary iris claw implantation that can lead to this disinclination. Too tight inclination in the mid-peripheral area sometimes lead to this pupil ovalization, but that will normalize with the time. IOL tilt and decentration is also reported with RP-ICL due to broken haptic, disinclination of the lens due to iris atrophy, improper surgical technique, ICL handling during surgery, post-operative healing, inflammation. IOP changes are the factors that can lead to the IOL tilt or decentration. Cystoid macular edema following ICL implantation ranges from 0 to 25% of patient. It is due to presence of chronic low-grade inflammation of the iris chafing, change in IOP or associated systemic diseases. So ICL implantation is a condition where ACIOL are the contraindicated and inadequate angle support, congenital angle abnormalities, anterior segment trauma, uncontrolled glaucoma, a very shallow anterior chamber, the nano-ophthalmic eye. These are the conditions where we can plan the this iris claw lenses. Now we are comparing which is better, the antipupillary or the retropupillary implantation. The risk of this IOL dislocation is more with the RP-ICL, but it is better than the antipupillary ICL because there's a antechamber is deep, so the cornea-related complications are less. There's a low endothelial damage, and the risk of high IOP rise is less with the retropupillary ICL. Limitation is this is a non-foldable rigid Palma lenses and need the sufficient iris tissue, and it can't be implanted in the patient of aniridia, iris atrophy, or a patient with recurrent iridocyclitis. The take-home message is IOL implantation can be done in any eye with sufficient iris support. Dilatation and constriction of the pupil is not affected. RP-ICL provide better stability and lower the risk of IOL tilt or dislocation as compared to scleral fixated lenses. Minimum endothelial cell loss with IOL and anterior to the iris or can be retrofixed. Minimum chance of raised intraocular pressure. Thank you.
Thank you so much, Dr. Prajita, for such a nice presentation. You have already covered the merit, demerits of all the options. So already you have left the audience to decide which option is better. Thank you so much.
Thank you, sir.
Now the last speaker is none other than Dr. Kamalji is a very renowned eye surgeon, has a very experienced, as I think the 40 years having practicing and work with me at RIO Prayagraj, and he's the international fellow, is going all the places, attending all the conferences, nationally, internationally. So he is going to, the various option is the nowadays the procedure that is iris lens and escape fixation are these are two popular procedure. So he is going to compare both the procedure and tell which is better. Thank you so much.
Thank you, Professor S.P. Singh. It's really an honor to be here in APO in such a wonderful convention center. We are almost all, I see Dr. Ruchi Goyal also sitting and all other faculty members and friends sitting there. We are all almost SICS people, and when we had started doing SICS, we used to say that we should continue working hard for a cheaper option. Although we are doing phacoemulsification in our Regional Institute of Ophthalmology, almost 150 surgeries are done every day. Despite every surgery being free of cost, the SICS is almost more than 85%. Okay, because the cataracts are such and the patients cannot afford many of the cases, and we don't have so many phaco machines that we can cater to all the surgeries. And then we have these kind of problems that you have a lens drop, IOL drop, or PCR, where you cannot implant a good foldable IOL or even 3-piece, PMMA lens. So in those cases, this comes in handy. And when I was coming to this convention center, I saw that the surgeons who work very hard day and night, they are sitting in such corner of the, because I couldn't find this trade hall to very easily, and you can see the industry is sitting there with such good halls and exhibitions and whatnot. They are providing us these chocolates and everything and we are sitting here talking about the academics. तो सरस्वती का जिससे कॉम्बिनेशन होता है, कभी कभी वो लगता है कि देखिए पैसा बड़ा ज़रूरी चीज़ है, और अगर SICS में भी बहुत पैसा कमाया जा सकता है और अच्छे से रह सकते हैं हम लोग, क्यों डॉक्टर रुचि? So we have this iris claw IOL versus scleral fixated IOL. Whenever you have a complication, as we have already discussed, we can implant a secondary IOL. And if you look at this IOL, this is the newest IOL that Dr. Kiranjeet from Amritsar, Dr. Daljit Singh's son and a famous eye surgeon, he has started doing this iris claw lens with 4 holes. Initially there used to be 2 places where he used to apply these, fix this lens into the iris, and now he has started doing it at 4 places, so that you can have a good fixation and there is no movement of the eye, this IOL in the eye. So that at times leads to cystoid macular edema and many other complications, iris chafing, pigment release, and all those things can occur. So he is these days doing this surgery in the anterior surface of the iris. Very soon you will find that this lens would be going into the posterior surface and iris fixated lenses would be. Pre-operative workup, only thing I would request you is to, once the complication has occurred, whatever, maybe the resident or a consultant is like, I consider myself resident in putting a iris claw lens. I used to have Professor S.P. Singh, Vinod, Aprajita, and so many residents who could easily implant this posterior fixated iris IOL. So whenever you have a complication, please stop there. Give a chance to vitreoretinal surgeon. Still we have this lens drop or nucleus drop. I go to RIO many a times. Now my son is also vitreoretinal surgeon, so many a times he can handle the things. So you don't go deep into the vitreous. चम्मच से निकालने की कोशिश नहीं करिए. अगर आपने चम्मच से निकालने की कोशिश करी तो रेटिना वाला परेशान हो जाएगा, रेटिनल डिटैचमेंट होगा, होल्स होंगे, टीयर होंगे, एंड whatever little chances are left would be gone. Otherwise, once the iris fixated IOL is implanted, it looks as if the normal eye is there. So this is what I would say. Options already have been covered by all the learned faculty. AC IOLs, scleral fixated IOL. Many a times anterior chamber Kalman lenses also work very well. Only problem is that in a big hospital setup, we don't have the proper sizing of the AC IOL, which causes problems. The complications of AC IOL like corneal decompensation, UGS syndrome, that is uveitis, glaucoma and eye fuma, they are all because of IOL sizing, and many a times we forget to do peripheral iridectomy after implanting the AC IOL. These days normally we don't do any peripheral iridectomy, so we must do a peripheral iridectomy, proper one. It should be open, and this will help you in many ways. If you are not very used to other kinds of IOLs, then you can easily implant a AC IOL provided you have done a good vitrectomy. There should not be any vitreous strand into the vitreous. Put triamcinolone there in the anterior chamber and wash it properly and remove all strands of vitreous in the anterior chamber. If they are left, they will lead to, supposing a strand is left in the incision, it will keep on pulling, it will lead to detachment, and it will lead to permanent cystoid macular edema. So you have to avoid that, and if you do that, you can put a AC IOL or a iris claw lens Anterior chamber iris claw lenses were popularized by Professor Daljit Singh, and those were excellent lenses. Still we find those lenses giving such very good results, but the only problem was the corneal edema. So that can occur in any case in some of the cases because the vitrectomy was not good then. So you can put a iris claw lens behind the iris also and fix it there. So basically what you have to remember is that the time that scleral iris fixated lens takes is very short, whereas if when you implant a scleral fixated IOL, then it takes very long time, and the complications which have been discussed by Dr. Aparajita already, these complications can occur in any kind of IOL, and you should implant only that IOL with which you are comfortable. अभी हमने आयरिस क्लॉ पढ़ाया तो कल से आप शुरू ना कर दीजिए. अगर आप स्क्लेरल फिक्सेटेड लगाते हैं तो वो भी उतना ही अच्छा है, और अगर एंटीरियर चैम्बर आईओएल आप अच्छे से लगा ले रहे हैं तो वो भी बहुत अच्छा है. कोई ऐसी वो नहीं है कि नहीं आप आईओएल पढ़ा रहे हैं, ये ना हो कि वो पीछे गिर जाए. सो दीज काइंड ऑफ थिंग्स कैन अकर, एंड all these complications have already been discussed by Professor Aparajita, and this is one scleral fixated IOL. I have not done this surgery, was done by Dr. Pranav, and so this is what I requested him to give to me. These two flaps are made on both the sides, and after making the flaps you make a opening into the flap wall that you have made, and after doing a frown incision you can see the vitrectomy was done, pars plana vitrectomy was done. It's already there. It should remain over there. It takes longer than the iris fixated IOL, whereas if you implant a iris fixated IOL, it's almost the same time that you take in implanting a foldable IOL, apart from the vitrectomy that you do. So these are some of the cases wherein you can implant these and suture them. There are some other modifications also in this, done by one of his friends there at Chitrakoot. So these are some of the cases that can be done with scleral fixated. Results are very good with all kinds of techniques. जो भी सर्जन को accomplished हो जिस सर्जरी में, that surgery should be done. I can see that in our department iris fixated lens is very popular, and almost our young residents can also put in a iris fixated IOL. Thank you so much.
Thank you so much, Dr. Kamaljeet Singh, for just campaigning both, and you have already told the any procedure, all the options is better. Only this depends upon your expertization. Thank you so much. And already we are running late, so we have to just leave the hall for the next session. So I request all the participants to have a good photograph, and thank you so much. If any query, any question, you may discuss any time, even in the later on. Thank you so much.